Hello, I'm Allison Arnold, and I'm with Central Michigan University. I'm with the Interdisciplinary Center for Community Health and Wellness, and I'm pleased to share this new resource that is a toolkit for behavioral health providers who are working in telehealth settings. This is part of an initiative that is called PRiSSM, which is preventing suicide in Michigan men. And in partnership with the Michigan Department of Health and Human Services and other partners around the state of Michigan, CMU has been tapped to put together this toolkit of resources to assist mental health and behavioral health and primary care providers. The toolkit, again, puts together resources on best practices, on unique strategies for serving men via telehealth, and it has a special emphasis on the continuum of practice that will be important for suicide prevention and assessment. This is really a significant area that's been identified across the state of Michigan by providers who are working with patients since the advent of COVID-19. Many behavioral health and primary care support services have shifted to telehealth delivery. And for the foreseeable future beyond this pandemic, many providers are saying that this is very important in their mix of practice to make sure that more patients have access to care. And so what we hope this toolkit will provide is a place where providers can go when they are looking for evidence-based resources, for tools, including screens and other simulation opportunities to view and to incorporate in their work with their clients. So once again, welcome to the PRiSSM Toolkit. We have organized the information around the Suicide Resource Prevention Center's continuum of suicide prevention, intervention, and postvention. In designing this toolkit, we've relied on an expert panel being led by Dr. Furhat Jansen, adolescent and child psychiatrist in the College of Medicine, who has assembled experts across the field in Michigan to assemble and curate the resources that you'll find in the toolkit. This is just being developed and implemented as we speak in late 2021 and into 2022. So we hope that as you begin to review this toolkit, that you'll feel free to get in touch with us and let us know how useful it is, what else we might be able to incorporate in the toolkit, because we really want to invite providers in practice to feel like this is an opportunity for them to have input to shape the tools and resources that we're sharing. As you'll note on the overview page of our site, our resource site for the toolkit, there is a contact link at the bottom that you can use to reach out to us, to indicate if you'd like to be part of a learning community that is currently underway that's enhancing and vetting this resource, or if you just have any questions or recommendations that you'd like to share. So please feel free to stay in touch with us and use that link to reach out.
So in terms of developing this toolkit, we were charged with, you know, the goals of reducing suicide for men in Michigan through telehealth. And, you know, that was kind of a big thing to chew on and, you know, even try to find a direction. And through good fortune, I was able to invite a panel of people to join us. And we had several people that were interested. And so we had representation from Collaborative Care through Mid-Michigan Health. We had List Psychological Services that had been doing a lot of telehealth. We had CMH represented by the expertise of Dr. Jonathan Henry, who we were hoping was going to be here today, but he has been a key member with contributing a lot of ideas. And so we were grateful for his participation. Dr. Leggio of the VA also participated. And then of course, our own Dr. Kai Anderson of our FHQC and CMU also participated. I have to give a shout out to our other crew, equally as important. We had Dr. Arnold and Andrea of our Interdisciplinary Center for Wellness. We had Dr. Nellie Regina, who helped with our toolkit survey. And then we had our medical students who you met, and this I've been continually impressed with their passion and their dedication and work on this project. And then have to give a shout out to CMU IT team, because they took what we had on paper and put it into the toolkit, which is now live, and we are continually revamping and revising that. So what we did when we first met is we all kind of brainstormed and researched, and we really kind of realized that there are a lot of telehealth toolkits out there. What you see listed, I'm sure as you guys were looking at your own processes, there's a lot of people who have developed various toolkits out there. So we really started to question, do we need to duplicate this? Do we need to set it up the same way that everybody else has done this? And we started to question, who is our audience? And realizing that our audience is, really the providers, and that with the two mission charges that we had, that we needed to interweave these two components into our toolkit. What telehealth components should be included to assist providers, and what components would be appropriate for adult men in Michigan to reduce suicide. And so what we were able to come up with is we all started coming back to this puzzle piece graphic from the Suicide Resource Prevention Center. And what everyone on that expert panel, the conversation we kept having was that suicide prevention and reducing suicide are not distinct points of care. It's a continuum, and you may have prevention, and then you may have intensifying care, and then you may go back to responding to a crisis. What about postvention? What about community things such as linkages and connectedness? And so we really resonated with this graphic, and what if we could do a toolkit that addressed each one of these puzzle pieces, and that the provider could have this right at their fingertips to click on and find the resources that they need for that point in time, no matter where they are on that continuum. This is proprietary. We did, the students, I should say, did contact the SRPC, and they were, this was created for use. So we do have permission to use it. We can't change it, but we do have permission to use it. Next slide. So now what we'd like to do is actually dive into the toolkit. I am not quite sure. I've given this talk several times. I think we might be on 4.0 version of the toolkit. So if those of you who have played around with the toolkit, seen it before, it may look a little bit different. But I want to dive into the different pieces, and also let you know that we know that this is not perfect. We already know there's things based on the feedback that we have received that we want to change already. And so, we are going to show this to you and hope for your opinions to make it better. So I don't know if you can go to the home page, Nathan. So if you go to this is located on the CMU website, and I'm sure somebody can maybe put this in the chat so you have a link to the toolkit. It starts with the PRiSSM grant and letting people know what the charge of the grant is. If you scroll down a little bit, you can see a little bit about telehealth settings and suicide care. If you scroll further down, you can see the puzzle piece there. And then if you scroll up, Nathan, over on the right are the pieces of the puzzle. So we have all the pieces of the puzzle that are on the right here. And then we added, as we went along, we realized that we needed a separate section for IT considerations, as our survey showed that providers really wanted help with some of the technical issues. And then at the bottom, we took all of the resources that are on the different pages and put them in just one landing spot. So if people wanted to peruse, all of the resources, they would be on that site also. Before we continue, I want to just take you through even more of the development that as we have worked with our cohort in piloting the toolkit, we've already received valuable feedback. One of the participants said, this is just really wordy. And even though there's a lot of things on here, it's almost exhausting to, look at all of these words. And what if we could just have graphics? And, if somebody, it could look cleaner and click on the graphic and take you to all of these words if you choose to read them, which we thought was really valuable feedback. So we're looking into that. At this point, Nathan, why don't we go to identify and assist? So let's say you're curious about this topic. If you look here, every page is set up with what the goals of that section are, what the different provider actions should be. Be aware of how common symptoms are, encourage community-wide recognition of risk, and different things like that, which are on each different section. And then there are actions in practice. So you can see here that this was one area that I think Dr. Henry assisted with, that we have a link to the PHQ-9. Nathan, if you want to click on that. So if people aren't familiar with that, then you can see that. Oh, is it downloading for you? So I don't know if you can go the Columbia scale. So you can just see that's just a way that these tools are right there at the ready. If you scroll down on the website a little bit to the telehealth practices, this also has been a little bit enhanced as we go along in our toolkit development. It talks about telehealth practices such as confidentiality, HIPAA, safety planning, where is the patient? How is there a person that you could call for contact if you lose contact with the patient? How can you ensure the patient's privacy? And then there are different resources there in terms of different platforms you could use for telehealth. There are also consent forms. Nathan, if you'd like to click on the CMU Mid-Michigan Health Patient Agreement, I'm sure there's lots out here. We got permission from each organization to show an example of a patient agreement for telehealth. So that's right there at the ready, because we don't know if a provider is working in a big system like a CMH that has some, has sophisticated practices, or like CMU or Great Lakes Bay, or is it somebody that's working rurally just by themselves? So some of this stuff is very needed. If we, Nathan, go back to the toolkit, and you can see that there's telehealth for the treatment of serious mental illness. If you want to click on that. So some of these might take some time because they download to a PDF, but this is actually a pretty rich resource on SMI and treatment that's there, and how you can use best practices for telehealth of these particular issues that present so often to us. Nathan, if you can go back. And so the last thing I want to show you here is, Nathan, if you scroll down, if you see providers, the last thing, providers best practice guide for telehealth. So this is the HHS telehealth practice guidelines. And so, you can see that there are things on billing or on different operational types of issues that people may need help with. And as we were developing the toolkit, this was one of our ideas, that we could put these things in the resources so they're there. We don't have to rewrite them, but they're here if people need them. Okay, so next I would like to take you through the responding to crisis section. Are we on it? I'm sorry, I'm having trouble seeing. Yep. Okay, so this is again the same. Say that again.
There you go.
Okay, sorry. I'm following on my screen because I have 54-year-old eyes, so so I'm trying to look at both things at once. So if you look again, you see the provider actions in practice. You see the screens there again. Telehealth practices again. And so this is one of the things, as we were developing this, we wanted to be consistent on each page, because we wondered, if you're looking for something really quickly, wouldn't it be nice to have this in each section? As we started to play with it, some people thought, you know what, this is a little annoying to see this, if you're going through it in each section. So we really don't know where the sweet spot is with that. Perhaps if we do go to a graphic kind of interface, that issue would go away. Again, you see the consent forms. And if you look down, Nathan, if you can click on the telehealth for the treatment of serious mental, oh, nope, we did that one. Oh, well, I guess where this is the one. If you scroll to resources and tools, so if you see the treating suicidal patients during COVID-19 best practices in telehealth. So this is a really nice, this was actually a seminar, and they provided these resources again to be utilized. And so this is a slideshow on how if someone presents acutely suicidal, how do you address that? And there's some really useful tips in this slideshow as well. It discusses virtual options for coping. Nathan, if you can now go back to the toolkit, I think Nathan's going to deserve a special award for all of these various talks I've given that he's had to try to follow me. If you could click on the discusses dialectical behavioral therapy, DBT skills. So this is a nice website, if it pops up, that you can give to patients in terms of in terms of resources and help. It's kind of a digital resource in terms of DBT skills. And so Nathan, you can kind of just scroll over each face, and it shows you the different options that you can utilize with your patients. Nathan, if you want to go back to the so I remembered now, I'm all over the place. So I think it was on the next, never mind. I think I missed it on the last slide of the last section. So we will just go ahead and now go to postvention. So if you look here, we wanted to address this as well. This is a topic that isn't really covered by most suicide prevention websites or toolkits. It's something we don't like to think about, but it is really important in our communities, and most of us are interested in helping our communities, helping our first responders. And so we wanted to include this. And, you know, what we are discovering with this is it really is about grief response and supporting survivors, you know, preventing contagion. And so there's some recommended practices here. And then Nathan, if you scroll down, there are, you know, Barb Smith's Suicide Resource Response Network and the American Foundation for Suicide Prevention. There's a lot of resources on postvention from these sites, you know, talking about how to help families, things that we don't think about in terms of cleaning companies and post-suicide cleaning, things that Barb Smith Suicide and Resource Response Network deal with every, you know, not every day, hopefully, but a lot, and that we can provide these types of supports for our community should we choose to. Okay, now if we can go to the IT considerations. So this is something that our medical students really worked hard on, and I am continually very impressed with them. And so they put a special page here just for the IT, talking about technical types of things, you know, also how to behave while you're on telehealth. And I laugh at this because both Dr. Anderson and I are in residency training education, and so these are things that we try to educate our learners on in terms of professionalism and privacy for our patients. It goes into the best practices for telehealth. And then Nathan, if we can then click on the resources and tools section. So the resources and tools section, you can see now you can open up any of these arrows, and anything that was previously on those pages, you'll be able to click on. There might be even more in here that may not have been included in those sections. So this is a really thorough part of the toolkit, rich in anything you might want to find if you want to kind of dive down the rabbit hole. And then the last thing is if we can go to increase help seeking. So this was one that was really important to the expert panel. Really, in this age and in our enhanced knowledge about being culturally sensitive and knowing the obstacles and barriers that some of our clients face, that we wanted to provide some resources regarding that. And so this section does talk about culturally sensitive collaboration. If someone is curious about how to do a cultural formulation in terms of an interview model, that's there as well. We do have in the provider actions, how you can consider men-specific needs, since this particular initiative is geared at decreasing suicide in men. If there's I can't say that word, mnemonic for reinforcing culturally responsive practices. And I think this really speaks to the comprehensiveness and the care and the patient-centered focus and provider-centered focus that this panel really had. It was a true pleasure to work with all of them, and I'm very grateful. And I do want to say that, we did have this expert panel, but we had people continually reaching out to us with ideas and suggestions. And so we're very grateful for that help as well. Liz Cunningham was very key in providing us with some great feedback about telehealth and working with toolkits. And Lauren Joslin also had some really great feedback for us as well. So Nathan, thank you for your navigation. You can stop sharing if you would like. And at this time, I would invite any questions, comments. Dr. Henry isn't here, but Dr. Anderson is. So Dr. Anderson and I would be very happy to entertain questions and help with anything that you may want to ask.
Dr. Jansen, I can just break the ice a bit. This is Bob Sheehan. I thought I knew PRiSM really well until I just saw that presentation. Holy smokes. I'm more dazzled than I was before. I didn't realize, to be blunt, that you had such great resources on telehealth practice in the much broader sense, as well as suicide specific. I think sometimes we get caught thinking, here's a new brand of animal called suicide prevention and treatment I have to learn. And your point is, no, it's embedded in here. I mean, yeah, there are specific interventions and resilient factors and pieces we can bring around it, but it's within this sphere. I'm using my hands like you can see them, sorry. Within the sphere of mental health treatment generally, and within a tighter sphere of telehealth. So thanks, by the way, for placing it there. I think it makes it easier, it makes more sense to a clinician to embed it in their telehealth practice.
Well, Dr. Arnold is very humble, as is Andrea Beatty, and they are kind of the brains behind all of us. So they really had a vision for the toolkit, and so they're very brilliant. And so I can't take the credit for that.
We recognize that this is all a continuum. And when we came across the suicide prevention resource continuum, honestly, that was Dr. Jansen and Dr. Anderson. That was just a conversation where the advisory panel just really coalesced around that said we need to create a toolkit for this whole continuum, prevention, treatment, postvention, and people can access this continuum based on their needs in their practice and with their respective clients. We needed to make sure we were incorporating the component for men as a unique and vulnerable population as part of our PRiSM work, but recognizing that this is much broader as far as its serviceability and applicability. And then also this arena of telehealth is just continuing to unfold. And that's where we're hoping with all of you and the advisory group, maybe we can team up, because we realize that this toolkit could be enhanced we've already had ideas for, can you show me a simulation of what this looks like if I'm in a consult that's on, via tele or via video? What does this actually look like, and how do I break down that best practice? And so we're hoping that some of the feedback that you will provide to us if you join us for the next few months might help us build some simulations. We have that in our medical school. We build simulations all the time with our standardized patient program. So we're good at that, but what we need help with is zeroing in on what are those problems of practice, or those challenges of practice that we can really make a difference by building a simulation for providers to kind of see and practice together. So that's one area which we do intend to build out and enhance the toolkit with as well.
Dr. Arnold, are you saying by that then that some of the pilot sites might serve as that to help flesh out what those simulations might look like?
Correct.
Okay, that's helpful to know.
Again, if there's interest, we're hoping there is.
Right.
So.
Well, you've got sort of an all-star lineup on this phone from across the state from our system. So I think there's at least one or two who will say, I wouldn't mind help building those simulators.
That would be great. And we have some holding places with our standardized patient team to begin to develop some ideas and scripts and things like that that can help us prepare those things. So it would just be a matter of kind of determining what a few priorities are. Ideally, as we look at that, all of those puzzle pieces, it would be wonderful to have a few simulations as appropriate in each one of those areas. So that's our aspiration. And the commitment that we would hope to invite you to think about is a series of 3 meetings, at least initially. And in each of the meetings, we'll dive into a very discrete part of the toolkit, and you'll have a chance to kind of dig into it before the meeting, and then come to the meeting willing to lay it out. What's working, what isn't working, what feels good, what is something that's missing that we need to build up. And we're really hopeful for that kind of iterative feedback. And I can share my screen again, but really I like this conversation a little better. Let me just go there. We've talked about the toolkit. This is kind of our Q&A time here. And again, this is the little bit of what we would hope that you would take part in is you get access to the toolkit, which you have now, but we would support that, potentially provide some professional education, continuing ed credits for those of you who would join us for the 3 sessions. Again, just we would hope to also enlist your ideas for trainings that you think are relevant, and possibly collaborate with the advisory group if there's interest in hosting some of these trainings. I think we even talked about, wouldn't it be awesome to host a telehealth summit on best practices in telehealth, telemental health and suicide prevention. So this is our team again. I'm going to stop sharing and just invite any questions, or I think the process would be to identify yourself if you'd like to kind of join us for a pilot. We've got the dates. You can maybe, how would you like to see that flow, Amy and Bob? Should they reach out to you first, or to us, or combination?
I think, Amy, couldn't they just reach out to the PRiSSM team directly? Does that make sense to you, Amy? I think you're on mute.
I think that would be fine. If anyone couldn't find their contact information, they could absolutely just send it to me and I can forward that on.
So this is Lynn Doyle. To me, it would be helpful to be able to go back to some of my staff who are actually boots on the ground doing telehealth and doing counseling. I'm far away from that at this point in my job, but I think they would be interested, but I just need some time to run the toolkit past them and say, hey, would you be willing to sit on this 3-part committee and give feedback? I think they would, but I need just a little bit of time to show this to people.
Lynn, would you want those slides to do that? Would that be helpful if the slides that we're showing today were provided?
I think so.
Sure thing. We can get those to you. And I think we have targeted those 3 meetings to start in January. So we would have time to kind of have folks give it some thought and reach out if there's questions. As we started our initial PLC or learning community, we had some individuals reach out and just had a few questions, and we're happy to have a conversation to whoever it makes sense, Dr. Jansen, myself, Dr. Anderson, whoever.
Allison, is the toolkit link in the slide?
Yes.
Okay, perfect.
Yes.
Beautiful.
And Andrea just posted the dates of the meetings, January, February, and March.
Those are not in the slides, Andrea. Andrea, those are separate. The reason I'm asking, I think Lynn's point's right. You want to be able to walk home to your staff and say, here's what we're thinking, and have it all in one spot.
I think the meeting dates are in the slide.
Oh, they are, you think? Okay.
Yeah.
Okay.
I may have just jumped over them.
It's okay.
And Allison, quick question, what is the continuing ed or the CE components that you guys are able to offer as well?
We would, again, based on the 3-hour participation rate, we would look probably at CME and social work. But CME also correlates to nursing. And so if there's, based on who agrees to participate, even if it's public health credits, we can try to wrestle those down for them.
Perfect, thank you.
So we are just so thrilled for your time today, and we won't exceed it, knowing that you've got a lot on your plates. And I've seen a few of you in a couple meetings already today, so I think it's just one of those days. But we hope that you'll reach out if you have questions. Amy and Bob and the advisory committee with CMH, if there are ever any opportunities to think about collaborating with the Learning Collaborative work, as well as even curating web resources. This could be something that just immediately, the PRiSSM toolkit could be something that you curate as well. So just, we can set that up however, it makes sense.
Allison, I think it makes a ton of sense. In fact, I was just thinking out loud, if you could, when you send the slides to us, whoever does that, if in the email itself, it could actually say, here's the steps you have to take to sign on to this. Here's the link. And then here's the due date. I'm thinking about Lynn Doyle's question. If she hands it out to her staff and or sends it out to them, they'll read the slides, but the question always is, okay, I'm pretty excited. How do I do this? If we could just make it simple, here's how you sign on. Here's the due date. You got to sign on by, what I'm trying to avoid is that first date of the session, the first session here, whatever date that is, January 12th, you don't get somebody saying, I wouldn't mind this. It just causes chaos at your end and ours, I think.
Sure.
Lynn, does that make some sense as you think about it?
And honestly, the toolkit itself is public right now. So you have the short link to go back and kind of look at it yourselves. But we will, in the subsequent email to everyone here, I think we have everyone's email. We can check on that. We will send you the link again. We will send you the contact for notifying CMU, yes, I'd like to be part of this pilot group. And then before the January meeting, we'll send out kind of a pre-confirmation and an agenda for the January meeting.
That's great.
Perfect. And I can also include that in our newsletter too, Allison, once I get just a good little short blurb.
Sure.
And
Sounds great.
allow people to sign up that way as well.
Super. Okay, yeah, thank you. I think some people are putting their emails in here if we don't have them already. So thank you so much. And I don't know, any last words from our team? Thank you, Dr. Jansen and Dr. Anderson, for your development effort, Nathan and Anushree. They really track down a lot of these resources. So, they kind of build it.
I just want to say again, thank you for the opportunity. I don't get to see often that the work that we're all doing, you know, in the same sphere. And it's just, to me, very exciting. And so I'm very grateful for the opportunity to speak with all of you.
Terrific. Well, thank you all. You have 4 minutes back to your day today. So use it to take care of your own, put on your own oxygen mask, I guess, for a few minutes, and we'll stay in touch then.
I want to thank our partners at Central for all your work on this front. Thank you very much.
Thank you.
Thank you.
Everyone.
Thank you.
Thank you.